Good afternoon, everyone. So again, my name is Shay Phillips. My pronouns are Z, Zir, and Zirs. I have done a whole bunch of stuff in an interesting collection of areas, but the reason why I am here today doing this and how I got into this work is that I am genderqueer, which is under the umbrella of being trans. It's a non-binary identity, so I don't identify as either a man or a woman, somewhere else in the very wide spectrum of gender. And I started doing a lot of this work in high schools, helping trans students access things like bathrooms and sports teams. And then when I went to grad school at UIC, I was trying to access gender affirming healthcare and had a lot of trouble with that, so started the Gap Advocates program, which also got me, while doing that, I was also involved with the Gender and Sexuality Center on campus and leading a lot of workshops that became very medicine focused because of what we were trying to do on campus to provide care to students. And I've just continued that work in a lot of different settings, currently both at Rush and also in the UIC Medical College. I feel like I do this because I want to have better medical experiences, but also I hear the stories of so many other people who are having a really hard time accessing healthcare, whether it's specifically about their gender or just care that respects them as a human being. So I am bringing a lot of my own personal experiences. My partner is also trans and a sociologist who studies trans experiences. I have a lot of friends who are trans. I have also done some of this research with standardized patients and also with trans people seeking healthcare. We did a couple of focus groups last summer just to kind of find out, what other experiences are out there and what do trans people want their providers to know about. So although I have a lot of personal experience, I also want to highlight the fact that I am just one person and I only have my own experiences that are shaped by a lot of the other parts of my identity. So I am also a white trans person, which makes navigating the world very different. I have had access to pretty good education. I was born in the US, have US citizenship, and have lived in mainly urban areas where care and access are very different. So although I try to bring in other people's experiences, I cannot ever speak to everyone's. And I think, especially when we're talking about trans healthcare, this is important to look at who's providing the information, because there's been a very long history of non-trans people trying to impose standards and expectations on what it means to be trans and who's allowed to access any sort of healthcare, and really who's allowed to be defined as a person. So before we get into the specifics of healthcare, I just want to make sure we're kind of on the same page with some basic terminology. So we generally talk about these 4 different aspects of identity, and they often get conflated as being either very tied to each other or the same thing, and I want to make sure that we recognize the differences in all of these things. Because we, in our current society, tend to stick to a binary that has a lot of assumptions, and we start with someone's sex assigned at birth. And we say, all right, you are either a male at birth or female at birth. And depending on which one the doctor or provider or whoever is looking at your genitals when you're first born, really, says you are, there are a lot of expectations about all of these other parts of your identity. So if you're assigned male at birth, the expectation is that you will identify as a man, present in masculine ways, and that you'll be attracted to women. Conversely, if you are assigned female at birth, the expectation is that you will identify as a woman, present in feminine ways, and be attracted to men. I think it's relatively well accepted at this point that that last point is not always true. You're not always going to be straight. But there isn't as much widespread acceptance about the fact that those other implications are not always going to be the case. And I always like to start with the assumptions we make about sex assigned at birth, because this is where our binary system starts with having only men or women. But if we look at the reality of people's bodies, we know that that isn't true. So we take this assignment based on what someone's genitals look like, and there are some pretty specific standards referenced up here in the corner. because the tissue that forms the clitoris is the same that forms the penis, and it just is a matter of how big that is. So if it's small enough to say you don't have a penis, they will assign you female at birth. If it's big enough, they'll assign you male. And if it's somewhere in between, there's a lot of panic. There's been more talk recently about the surgeries that are performed on intersex infants' genitals to normalize them. And among intersex people, the kind of standard response is, we don't want that. We want say over our body, and it's okay to be outside of that norm. And when we look only at infants' genitals, we're also ignoring everything else that we assume about sex assigned at birth. So looking at people's internal sex hormones, or internal sex organs, the hormone levels, the chromosomes, and how they develop during puberty. Lost my train of thought there for a sec. And even when we have people who fall within those two typical male and female designations, there's a lot of variation in how all of these show up. So I think it's helpful to recognize from the beginning that we're talking about a wide range of bodies and possible configurations of what those bodies look like, both at birth and throughout the lifetime. Yes, so a couple of things. So when we're looking at assigning we're assigning a sex at birth as opposed to sexual orientation, which we'll get to in a couple minutes. And the term hermaphrodite is an older term that people who themselves are intersex have really pushed to not be used, because it is generally used as a pretty derogatory term to imply that people are not fully human. And also, if you look at the origins of the word, it's not medically accurate. So there are other species of animals that are truly hermaphroditic, where they have entire male and female reproductive systems, which doesn't happen in humans. So the people with intersex traits are largely advocating for using the term intersex traits, or differences of sex development. In some of the literature, there's more use of DSD as disorders of sex development, but again, people are saying, like, we're not really, this isn't a disorder, there's nothing inherently wrong with it, it's just different. And so we'd like to recognize that it's different. And when you have situations where those conditions are not evident until puberty, there are a very small handful of those things that do cause medical complications, but a lot of them don't. They just cause your body to develop differently, which again is true for anyone going through puberty. Everyone's body is gonna wind up looking different. So there are some people who say, I strongly identify as this or that, and want my body to reflect the standards for that, and that then they can have access to surgery or hormones. But there are also plenty of people who say, I see nothing wrong with my body the way it is, and I'm totally comfortable with however it develops. And as long as it's not causing any medical issues, just leaving it that way. Is that? The expectations that we jump to from the sex assigned at birth are related to gender. Gender is a very socially based construct of what it means to be a man or a woman, or in some societies and at different times, there are also very well-recognized identities outside of being a man or a woman. And these, again, are varying between those cultures, but also across time. So even in the US, if you go back to before World War II, all little boys were dressed in pink because it was a strong masculine color, and little girls were dressed in blue because it was a soft feminine color. And then during World War II, with changing prices and availability of dyes, some clothes makers and toy makers decided to switch those colors, and now we would never consider it being something different. But there's nothing inherently masculine or feminine about either of those colors, really. And the expectations around gender are going to look at a bunch of different aspects of how you identify, present, and interact with the world. So if you think about your concept of either being a man or a woman, there's generally a lot about how you cut your hair, how you dress, how you interact with people, your likes and dislikes, what types of jobs you go into, and how you hold your body in general. But none of these are actually that set. And if you ask two different people, even if they are raised in the same area at the same time, they're probably going to have some slightly different ideas of what those rules should be, because they are created by the things that we're influenced by. So when we're talking about individual people, we talk about gender identity, which is how you think of yourself in terms of those gender categories. And again, the possibilities for gender identity are going to be very different depending on the concepts of gender in your culture and your time. And then we also talk about gender expression, which is how you show all of this to the world. So as I referenced before, this often comes across in haircuts and clothes and accessories and makeup or lack of makeup, how you hold your body, your ways of talking, and a whole bunch of different things. And I think it's really important to consider that not everyone's gender expression necessarily aligns with their identity. If you think about, on a daily basis, you get dressed in very different ways. Some ways reflect your identity more than others. Sometimes your identity just changes with the context and the particular day. And when we're talking about interacting with other people, no matter how you're presenting yourself, the way that other people understand that is going to vary. And we talk about this as how people read you and read your gender. So like an example from a couple of years ago, I was going grocery shopping. I was dressed in nothing particularly exciting, but I was in one aisle of the grocery store and someone was trying to get past me and they said, "Excuse me, ma'am." And then I went to the next aisle where I did not change my clothes, and someone said, "Excuse me, sir." And they had picked up on very different things. They were still both wrong, but they were making meaning of what I looked like, and neither of them were what I was trying to convey or who I am. And then finally, we have sexual orientation or sexuality, also sometimes referred to as sexual identity. And this has a whole bunch of different components that we don't always talk about as being separate, because for a lot of people they do align, but they don't always. So part of the sexual identity is how you think of yourself. What labels are you using? How do you understand your attraction to other people or your lack of attraction to anyone? And so that's the kind of identity part, but then there's also the sexual attraction of who you are sexually attracted to, who you are interested in having sex with, who you are turned on by, and what qualities in those people cause that attraction. There's also romantic attraction, which is much more about who you're interested in being in a relationship with, because of the more personality traits as opposed to what you're interested in and who you're interested in sexually. And all of those things may be very similar, but don't always have anything to do with actual behavior. So there are plenty of people, especially young folks, who will identify as gay or straight, but only sleep with people who you wouldn't expect based on that identity. And for some people, this is an issue of safety in terms of who they feel comfortable being around, how they feel comfortable identifying. And again, some of those might align with thoughts and fantasies that folks have, might not. And I also want to point out that, again, not everyone experiences sexual or romantic attraction. So there are a couple identity terms, asexual and aromantic, where people don't experience any sexual attraction or romantic attraction. There's also a spectrum of experiencing those attractions or not, which is generally referred to as the ACE spectrum. Again, all totally normal variations. However, they're generally not recognized as being valid identities and valid experiences. And then, in addition to that, we have people who form relationships in different structures. So our general expectation is that the monogamous relationship is an ideal, where you're in a relationship with one person and only one person at a time. And for some people that works great. For some people it doesn't. And this generally falls under the umbrella of polyamory, where you have the potential to form relationships with multiple people at the same time. One of the keys in doing this is generally communication with those partners, letting them know, this is what I'm interested in doing. Let's set up the rules for that. Because if you don't do that, it is still cheating. If you don't have that common understanding and respect in what you're doing. All right, before we go on to the next stuff, any questions, clarifications so far? Yeah?
When did it come about that you referred to as thee or they instead of gay or lesbian? Or when did the word thee and they come in to be what we're supposed to accept?
So using the pronouns they and them for one person is a recognition that he and she don't always adequately reflect someone's gender identity, so separate from being gay or straight. So often when someone identifies as a man, you refer to them as he or him, and when when they identify as a woman, often folks want she and her, but for people who are outside of that, we need other options because the English language is not particularly gender neutral. However, they and them as singular gender neutral pronouns, so pronouns that are used to refer to one person as opposed to a group, have been used, as far as we know, since at least the 1400s in English, and have been used by some really canonical authors such as Shakespeare, Chaucer, Jane Austen, because we often need that pronoun, one, if you don't know someone's gender, or if it doesn't matter, or if someone identifies outside of that binary. And we do this all the time, even if you're not trying to be inclusive of gender neutral identities. So if someone says, I went to the doctor the other day, if you don't know who their doctor is, you might ask, oh, what did they say? And you're still talking about just one person. You just don't know who they are, so you're not assigning a gendered pronoun to them. And this shift has become much more popular within the past 10 years or so of more widely using they and them, because before that, a lot of queer and trans folks were using different pronouns. So my pronouns, sie and zier, were one of those more popular pronouns, and also a slightly different form of that, sie and here. And what was happening was that outside of trans communities, if you ask someone to use them, people would say, oh no, you're making up words. I can't possibly learn these and make sense of it. And so in response, people said, well, you use they and them all of the time, so use that instead. But again, they and them has been used for a really long time. And my pushback to the idea that words are made up is, can you think of a word that is not made up? We have created all of language to identify our experiences and to describe what's happening in our world. This is just an extension of that, to say the language doesn't fit my experience of myself, so what can I use to convey what I actually want to convey about who I am? Yes?
So just to clarify, using they or them is the more accepted newer way rather than the ze and zers?
So it's a personal thing. I think there is more widespread use of individuals saying my pronouns are they and them. And there are still other people besides me who use ze and zier. It's just not as widespread. They and them has become more common use when you don't know someone's pronouns. So instead of saying, especially in writing, the he/she, which is also really awkward to say out loud, you can shorten that to say, they, when you're talking about someone who you don't know, or just kind of a general person.
They and them are plurals. You're a singular. Why is it they and them?
So we can look at the use of you, which is another pronoun. We currently use you to talk about one person, or you, all of you. Previously, we had thou, which was the singular you, and people got rid of that and just started using you in general. The idea that they and them is singular, or is only plural, is, I'd say, just not an accurate reflection of the entirety of the English language. And again, we're figuring out how to use language to accurately reflect people's identities. And identities are determined by existence and experience and not necessarily language.
But if you know that person's name, they will not be insulted if they call you by your first name, which is big shit.
Yes, most likely, yeah.
Or that you're Charlie or something.
Yeah, but if...
That's not an insult then. You can say what that person's name is,
Yeah.
unless they specifically say, I'd rather be called they.
So,
Or that.
so
It's very confusing to be in public and you're dealing with a person you don't know, and you don't intentionally want to insult anybody, but when they say, well, my name is they, okay, I got it.
yeah, so people don't generally say that their name is they. They would say their pronouns are they and them. So just like for anyone else, if I were talking about, I'm going to make up a person named Mary who uses she and her pronouns, I might say, oh, perfect. Promise I didn't plant that. So if I may talk about you for a second, is that okay?
Go ahead.
So I might say, there's this person, Mary, who was, in the front row of the presentation, and she was asking a bunch of questions, and especially about pronouns. And so I would say Mary first to identify who you are, but then it would be really awkward if I just kept saying your name. So instead of saying like she asked questions, if I said Mary asked questions, and Mary had a lot of thoughts about pronouns, and Mary did this, it's going to sound very awkward.
Call me she.
Yeah.
Yes, I will. Yeah.
So if we had someone here who used they and them pronouns, I would start with their name to identify who they are, and then I would most likely switch to they and them because that's how we talk. So it's generally not going to be an insult to someone to use a name that they have provided, but they and them or any other pronouns that they're using become a replacement for their name, just like when you're talking about anyone else who uses he and him or she and her pronouns. Yeah.
Would you explain a little more about the ACE spectrum?
Yeah, so when we're looking at largely it talks about in terms of sexual attraction and romantic attraction, the general assumption is that people experience these things, that they are sexually attracted and romantically attracted to some people, generally not everyone in the world, though that could be someone's experience. But for people who are on the ACE spectrum, they generally experience less to none of that attraction. So for someone who identifies as asexual, that's generally implying, but again, this is a personal identity that varies from person to person who uses the term. It's generally going to mean that they don't experience that sexual attraction. They never feel that attraction to a particular person. They never feel particularly turned on by anyone. But for each person who identifies in this way, the way they act on that might be different. So there are some people who are asexual or on the ACE spectrum who never want to have sex, and they never do. There are other people who are okay with having sex sometimes, especially in the context of a relationship when their significant other does experience sexual attraction. It might be like, this is fine. Like, I wouldn't do this just because I want to, but it's okay. And for other people, it's I never want to have sex. I never have the desire to do it. And similar for romantic attraction, some people really want to be in relationships and experience attraction to other people where they want to be in a relationship with a specific person because they're attracted to them. For people who are aromantic or somewhere on that spectrum, they either just have no interest in being in a romantic relationship and won't do that, or they only find that they are attracted to people in very certain circumstances or very rarely. So within the context of these identities and concepts, we talk about being what it means to be trans or non-binary as someone whose gender identity does not align with what we expect from their sex assigned at birth. So anyone who is assigned female at birth who identifies as anything other than a girl or a woman can fall under that trans umbrella. And anyone who's assigned male at birth who doesn't identify as being a man, so that could be identifying as a woman or non-binary or third gender or genderqueer, gender fluid. There are a very wide range of terms. They're under a trans umbrella. Each individual person might not use the word trans, but for the context of what we're talking about, we're going to look at kind of the umbrella terms of anything other than what is expected based on your sex assigned at birth. And actually, going into non-binary terminology, so non-binary is the contrast to the binary identities of being a man or a woman, so pretty much anything other than that. And there's been kind of ongoing conflict and debate about whether non-binary people are trans, and especially whether they are trans enough. This is often a kind of harmful debate to get into. If people are identifying as trans, whether or not their identities are non-binary, they are trans. And also, non-binary folks experience a lot of the same societal pressures and also risk factors that binary trans people experience. So I generally just use trans as the umbrella to not separate those experiences out, because while there are differences, just like there are differences based on any particular identity, I think it's helpful for the moment to look at them more collectively and to acknowledge that you don't have to be someone assigned female at birth identifying as male, or someone assigned male at birth identifying as female to be trans, and that any way you identify is going to be trans enough. Related to these terms, a couple important things to talk about are the terms cisgender. So this is in contrast to transgender, trans meaning across or beyond. Cis as a prefix means same. So this is folks whose sex assigned at birth aligns with their gender identity. So it's the expected at this point in our society. So anyone who is assigned female at birth and identifies as a woman or a girl or female. Anyone who is assigned male at birth and identifies as a man or male or a boy, depending on age and personal preference for those terms. And then another term that comes up a lot when we're talking about trans folks is dysphoria. So this is the current diagnostic term used in the DSM for experiencing gender dysphoria. So the distress based on your body or your identity not aligning with your body and the expectations for you not aligning with your identity. And so some trans people experience really intense dysphoria, very intense discomfort and dislike, and sometimes dislike of their body, but not all trans people do. There are plenty of trans people who are totally fine with their bodies, even though it is not what we expect based on how they identify. So now focusing more on healthcare. Why does it matter to talk about gender-affirming healthcare? And my argument to you is that it actually matters for every single person, not just trans folks. So everyone, and I have changed this from my original statement many years ago that everyone has a gender, to not everyone, or everyone has a relationship with gender, because there are people who identify as agender, which is essentially no gender. And honestly, if I can self-identify, my response to what is your gender is no. It doesn't work for how I understand myself and my existence. But because of the society we live in that is heavily gendered, we all have expectations based on what people think our genders are and how we express them. So every time we are interacting with anyone, there are expectations based on how other people are perceiving our gender and our sex assigned at birth. And these are also going to come into play whenever you're interacting with a healthcare professional, because they are another person in society who's going to have those same expectations. And a lot of healthcare is changed a little bit based on how you perceive someone's gender and sex assigned at birth. And for trans people in particular, because of these expectations and also a lot of the negative assumptions and beliefs held about trans people, we experience particularly bad health outcomes and have particularly bad experiences with healthcare providers. And the negative healthcare implications and health outcomes are not inherent to being trans. It is largely about how other people perceive you and react to you. There have been some recent studies, particularly done with trans youth, where suicide attempt rates are astronomically high compared to cisgender populations. But if you look at trans youth who are in supportive environments, so supportive homes, family life, school life, those rates of suicide attempts and also depression and anxiety go way down to about the level of all of their cisgender peers. So it's nothing about being trans in particular, it's about how everyone responds to you because you are trans. So just to highlight some of those negative healthcare outcomes and experiences for trans folks, the first thing is we don't actually have significant data on this because most studies do not allow for an option to identify as trans, and there's very, very little funding for anything more recently that looks specifically at trans people, but everything done in the past pretty much has the option, are you male or female? For someone like me, I don't have a good option, so I have the potential to participate in a study and give you an answer based on what I think you want, and you can learn from my experiences, but you will never actually capture the fact that I am trans because the parameters don't allow for that. But there has been a little bit more work in this area as of late in about the past 10 years. So in 2015, there was a US transgender survey that was a follow-up to, I think it was a 2008-2009 survey, that both of these became the largest sample of trans people in the US to date. And they did an online survey that captured a lot of different aspects of what it means to be trans in the US and what people's experiences are. The report that came out of the first one was called Injustice at Every Turn, looking at every single facet of life and how it's essentially harder being trans because of the discrimination that folks face. But some of the things that came out of the 2015 version of this is that approximately a third of the people who had seen a healthcare provider in the past year had a negative experience. And this ranges from refusal to treat folks because they're trans, verbal harassment, having to teach providers, and some people also experience physical harassment and abuse at the hands of their providers when they were seeking care. About 23% did not seek healthcare because they were afraid of what might happen, and about a third didn't go to a healthcare provider because they couldn't afford it. Trans folks are more likely to live in poverty and to be unemployed or underemployed. And all of these are, and then tied in also with having issues with insurance even for folks who did have it. All of these statistics are going to be more significant for trans folks of color, particularly trans women of color. So when we are looking at gender affirming healthcare, again, we have to define what the scope of this is. And a lot of what we talk about for trans affirming healthcare and gender affirming healthcare is looking at hormones and surgery. So these are what comes up in a lot of the excuse me, insurance debates of what's covered and providers not providing or not being willing to provide care. But we need healthcare beyond those things as well. So every instance where you interact with a healthcare provider has the opportunity to be affirming, and specifically gender affirming, which means that the healthcare interaction and everyone involved recognizes, affirms, and appropriately responds to your gender identity and your experiences. So it's not just about getting surgery or hormones, it's also going into the doctor or a nurse and saying, you know, I have a broken arm and I need that to be fixed. A lot of providers, enough to the point that there is something called the trans broken arm syndrome, will say, you broke your arm, it's clearly because you're trans, and therefore I will not provide care. And often, especially for something like that, which generally has nothing to do with the fact that people may or may not be on hormones, the initial response is, you have to go off of your hormones in order to do anything about this. And there are also instances of people saying, you know, I might be able to treat your broken arm, but because you're trans, I will not talk to you, I will not touch you, and you are not allowed to receive care here. And then even more severe instances of folks not receiving appropriate care to the point where their injuries or their condition becomes life-threatening, and there are plenty of instances of providers watching people die because they have figured out that they're trans and are refusing to provide any care for them, despite the fact that the care has nothing to do with the fact that they are trans. So, on a more positive note, what can we do to provide gender-affirming healthcare? So, we as trans folks know that medicine as an institution is not particularly welcoming to trans folks. So in order to provide gender-affirming care, you have to be very proactively inclusive. Don't wait until someone has an issue. Figure out what you can do ahead of time to both prevent those issues and also make it evident to people who might be seeking your care that you will be inclusive. And in this whole process, don't make assumptions about people based on their appearance or what they say their identity is. Really listen to who they are, why they're coming to you, and their experiences. And recognizing that they, as patients, have really important information that you don't have as a medical provider. Healthcare should be a collaborative effort where the medical providers have access to a lot of knowledge, a lot of experience, a lot of tests that they can run, and outside resources, but your patients have the knowledge of their bodies and their experiences, their daily lives, of what brought them here, and also what could potentially work in their lives in terms of what kind of treatment plans are going to be successful. And you need knowledge from both of those realms to successfully care for folks. And in all of this, as I said, medicine has not been a particularly welcoming place, but when you are working within it, you have to be aware of what has impacted trans folks, why they might be wary of your care, and why they might be wary of interacting with you, and also what are they experiencing outside of that that might contribute to poor health care, and what can you do to make sure you're addressing it. So if a trans person comes and has a medical condition that you can treat, you also have to look at, all right, do they have housing? Do they have health insurance? Do they have a job? Do they have a supportive family or friends, a network of people who can help with this care that we kind of generally assume people have when they are accessing care? And while you're doing all of this work, there's always more work to be done. There's always more to learn. This is true for trans folks as well. As I said, I know my own experiences and the experiences of my friends, but there are always more identities that people are talking about, different experiences that I haven't had, but I can stand to learn more about to make all the work that I'm doing and these types of presentations more inclusive. And then ultimately, the goal in providing gender-affirming healthcare is to provide quality medical care. Make sure that you are doing everything that you would do for any other patient. Make sure you're not one of the people who is saying, must be the hormones, must be because you're trans, or I won't treat you. So some of these things that you can do proactively is to look at what is the entire experience of seeking healthcare, from figuring out where to go, to registering, to talking to the front desk staff, to being in a waiting room. What does that look like, and how can you make it more inclusive so that people know that you, one, know what you're talking about, but also have ways to recognize who they are. So this comes up a lot in paperwork, where you can add a field for a name that someone does actually go by, which doesn't always align with their legal name. Field for pronouns so that people can offer it ahead of time and say, you know, this is how you should address me. And also with honorifics, so this is Mr., Miss, Ms., Mrs. I think I got all of them in there, maybe not. So there's also a gender-neutral honorific that's coming into more widespread use, mix, MX, which is just indicating it's a neutral thing. But other folks don't want an honorific at all. And in a lot of forms, you have to choose something, and it's not an option to just leave that blank. So it's helpful to recognize that people are going to want different things, and it's not always the most respectful thing to call someone Mr. or Miss. And then in order to gather more information about people's experiences, and especially in terms of research, make sure you're accurately collecting sexual identity and sexual orientation, gender identity data, so that you, one, are making sure you're respectful and aware of who the person in front of you actually is, but also when you have records, making sure that you can identify when someone is trans and the range of identities that fall under that. So in order to do this, first have to recognize that those two things, sexual orientation and gender identity, are separate. So a lot of older forms will say, are you gay, lesbian, bi, or trans? Trans is a gender identity, whereas gay, lesbian, and bi are sexual orientations and don't make sense to have in the same question because you can be more than one of those things at the same time. So separating those out into different questions of sexual orientation and then gender identity, and also gender or sex assigned at birth are helpful. But also making sure when you're doing this that patients know where this information is going. It is not always safe to be trans, so knowing where your information is going that could potentially put you at risk is very helpful to know, okay, this is just going to the provider that you're seeing as opposed to like every single person at the front desk, because you might not want people to know that. And then, again, with that experience of being in the waiting room, who's there, what materials do you have in terms of posters, magazines? Do people feel safe and represented in those visual representations of what your practice is? And also, do they have a place to go to the bathroom? So this is a huge deal for trans folks because of the very gendered nature of bathrooms in general and the increasing number of bathroom laws that are trying to prevent us from going into bathrooms, and the lack of gender-neutral bathrooms, which is something that is what I want as a non-binary person. I don't want to go through a door that says man or woman because it doesn't represent who I am and also puts me at risk for people who are alarmed by my presence in those spaces because of how they're reading my identity. I have been very fortunate in that I have only had a few uncomfortable conversations, but people get beat up all the time when they are in a bathroom that people don't want them to be in. They get the cops called on them. It's not safe. So the next step after these initial interactions where you can work on being inclusive is thinking about how you do introductions with patients. So I work in a medical school where med students are learning how to do this, and they are often taught, you look at a chart and look at the sex, the last name, and say Mr. or Miss, whatever the name is. It doesn't work for everyone. For me, makes me really uncomfortable and not really open to sharing anything about my health or my body because that initial interaction is very off-putting and can also be dangerous in waiting room settings where you can potentially out someone for being trans if their appearance doesn't match that gender label on their forms, and again, can put people at risk for violence. So a really simple way to do this is to switch things up. When you are introducing yourself to a patient, introduce yourself first. Say, hello, my name is, and with your title, whatever is appropriate. You can also offer your own pronouns to kind of normalize that interaction and recognize that another person is not automatically going to know your pronouns based on how you look, and that gives space for other people to offer their own pronouns. So if I come up to someone and say, hello, my name is Shay Phillips, my pronouns are ze, zir, and zirs, that signals to someone else, oh, this person knows that I'm not, or that they're not assuming, and so I can offer my own pronouns. Sometimes this does confuse people. It's also a great time to provide education. As medical providers, you're doing a lot of education on a daily basis. This can be something that you can tie in if someone gives you a questioning look or asks an actual question about it. Just say, I don't assume people's pronouns based on their appearance, just like I don't assume their name. So when I'm introducing myself with my name, I provide pronouns so that you have the full information you need to talk about me and refer to me. And along with this, because we're not assuming anyone's name, except I apparently knew your name, it can be helpful to not use people's names until you verify what they are. So even if you have something on paper, it doesn't mean that that's what they go by and that's what they're comfortable with. So by asking for someone's name or how they would like to be addressed instead of reading it off a piece of paper, you can make trans folks much more comfortable. It's also really great for anyone who goes by a nickname, anyone who goes by a middle name, anyone who goes by an anglicized version of their name, anyone who is just very specific about how they want to be referred to. I know this was a huge deal for my grandmother, who became Dr. Donnelly later in her life, and so if people referred to her as Margaret, it felt not as respectful. And so in this situation, she would say, you can refer to me as Dr. Donnelly. And that just makes her much more comfortable and can be true for many other people as well. And when you're doing this, make sure that you actually take note of what someone is telling you. So it's not enough to just ask for someone's pronouns, but you have to actually use them also. And just because someone has given you their pronouns doesn't mean you actually know anything else about their identity. So I could say my pronouns are ze and zir. I told you previously that I identify as trans and genderqueer and a whole bunch of other things, but just because I'm using those pronouns doesn't actually mean that I have any particular identity. Just the same as there are plenty of non-binary folks who I know who use he and him or she and her. So just because you know those terms doesn't mean you know anything else, which becomes particularly relevant when you're doing more of the healthcare stuff. And I want to, before I go on, I acknowledge that using different pronouns can be tough. They're new words, just like any other new things. It takes practice. I do this all the time. I still mess up my own pronouns sometimes, and my partner's pronouns sometimes, and plenty of my friends who use different pronouns. But what I did when I first started, actually before I used ze and zir, I had a friend who used ze and zir, and so what I would do was have conversations in my head about this person and make a point of talking about my friend when my friend wasn't around so that I could more naturally use those pronouns and not make it a big deal in front of this person. And it took work, but it was really helpful. My cats also now use the pronoun ze and zir because it was another way for me to practice that because I talk about my cats a lot. And then if you're still having trouble, especially when using non-binary pronouns or any pronoun that you feel doesn't fit based on how someone looks, it's important to think about what is causing that for you. Why are you having problems with it? Is it because it's a new word or because you haven't shifted in your mind how you view someone? So if you are looking at someone, this happens to me all the time, people, especially once they hear my voice, say, oh, you are definitely a woman, I know. And even if they are trying to be respectful and using my pronouns sie and zir, because they have that conception in their head that I am a woman, they revert to she and her. It's important to believe when someone tells you what their gender identity is and figure out, all right, how do I switch that picture in my mind of who you are so that if you say she and her, it just sounds wrong. So at this point, when someone refers to me as she and her, because it doesn't correspond with how I think of myself, it used to be more jarring, and now it's just like, who are you talking about? Like, I don't actually know, because that's not who I am, because it sounds that unfamiliar, just like if you have a cisgender friend who, say a cisgender man who someone accidentally refers to as she, your reaction is like, oh no, that's wrong, because I picture this person as a man, and so he and him are appropriate. For everyone else, you make sure you're listening to who they say they are and creating that picture for yourself so that it's easier to align those correct pronouns. How am I doing on time? Oh, a little late. Let's go through this really quickly. So some of the things, or some of the instances when gender comes into play a lot is doing a health history. A lot of providers get concerned when they know that they're talking to a trans person, or like, I don't know like how to talk to you, how to ask any of these questions, what's appropriate. So it's really helpful to make sure you're asking the same questions to everyone. When you're taking any sort of health history, you generally need the same type of information. Figure out how to make those things most inclusive from the beginning so that it's not a new experience when you're dealing with a trans person. Also, you don't know if someone in front of you is trans or not. So you don't want to make that assumption from the beginning of like which script to use for the health history. Particularly talking about urology-based things and bathroom behavior, this is going to be a really important thing to ask about because, especially for trans folks who feel unsafe in bathrooms, this might impact a lot of their health and potentially the reason why they're seeking care in a urology realm. People avoid bathrooms all of the time, which causes a lot of medical problems in terms of infections and messing with muscle structures and stuff like that. So make sure you're asking because you want to be aware of what is actually impacting the health concerns that people have. And, excuse me. This can be even more dicey when you come to taking a sexual health history, which again is going to impact a lot of different aspects of health. So key things take away from this is make sure you're being as specific as possible. The kind of standard question of, are you sexually active, is incredibly vague. Does that mean, have you ever been sexually active in your entire life? Have you been sexually active in the past 5 years, 1 year, 6 months? Make sure you know what question you need to get the relevant information to what you are asking. And also, just because you have asked sexual orientation doesn't mean that you know anything about sexual behavior. This is also true for all straight patients. Just because they're straight, and even if they're in a straight monogamous relationship, you don't actually know what type of sexual activities they're engaging in unless you explicitly ask. And those can have a lot of different health implications depending on what body parts are involved, their own and their partners, if they're using anything else, such as toys or other objects. So making sure that you are figuring out what you need to know to provide the best care and asking those questions to make sure you get at what is actually important and relevant. So don't ask people's sexual health histories if it's not relevant. It makes people really uncomfortable, especially trans folks who are often asked about their genitals and sex way more than any other person is. So also explaining why you're asking each question can be really helpful. Similar for physicals, for people who experience dysphoria, this can be an especially sensitive thing, but not all trans people experience dysphoria, so for some folks it's totally fine. But also, dysphoria or not, people have different relationships with their bodies, how comfortable they are with being exposed to someone else, with someone touching them. So make sure that you're telling people what you want to do, why you want to do it, and asking for consent for every step of what you're doing. And when you're talking particularly about body parts that have been gendered in our society, so this generally is genitals, some internal sex organs, and chest development, because of the gendered ties with those names, some people are really uncomfortable with them and don't use them for their own bodies. So you can ask. You can say, how is there a specific word you use for your genitals or your chest? And then use that word when people supply it, because it's going to make people feel much more comfortable and much more forthcoming with all of the information that you need in order to provide appropriate care for them. Whoops, sorry, wrong way. And all of these things in terms of people's identities, terms that they use for themselves in terms of pronouns or body parts, have the potential to change over time. So just because you've asked once, if you see a person multiple times, make sure that you're checking in, make sure that this information is still accurate, just like you would with a lot of other aspects of health. It's going to change. And I think this is the final slide. You're going to mess up. As I said, I do too. It's a reality of life. But there are some better ways than others to handle this. So what sometimes happens is, one, just ignoring it. If you mess up, don't do that. But also, people tend to apologize really profusely and expect trans people to do the emotional labor of making sure that they feel okay that they just messed up. Don't do that either. When you make a mistake, it is not anyone else's responsibility to make you feel okay about it, especially in a situation where you're providing care. So my recommendation is to say sorry, fix your mistake, move on with whatever you were doing, whether it's an interaction, providing care, talking about someone else. Don't make excuses, and just take this as a mental note to say, I need to get better. Here's one thing that I can work on, and make even more concerted effort to not make that mistake again.